My name is Angela Smith, and I'm a third semester DNP FNP student at Washington State University. This policy change proposal is for updating the pain management and prescribing policy of a neurosurgical practice with which I work. Over the course of this practicum, the organizational and developmental core leadership have been very engaged and supportive. This is an issue of identified priority across the system, and the momentum from this project has expanded my involvement in several other related projects for quality improvement and implementation of best practices for pain management and continuity of care. The current pain management policy of the neurosurgical practice reflects a traditional biomedical model that encourages interdisciplinary treatment of painful conditions conservatively with physical therapy, injections, exercise, and weight loss where appropriate to avoid or delay surgery. For postoperative pain management, patients are prescribed a narcotic pain medication and muscle relaxant to use concurrently as needed and refilled upon request for 12 weeks post-op. Morphine equivalent allowances for most patients are 120 to 180 milligrams daily, with higher allowances for patients with developed opioid tolerances from chronic use. Patients leave the hospital with prescriptions for 120 tablets of a narcotic pain medication, such as oxycodone, hydrocodone, or hydromorphone, and 90 tablets of a muscle relaxant, such as diazepam, methocarbamol, cyclobenzaprine, or tizanidine. Neurosurgical procedures are recognized as some of the most painful surgeries with prolonged recovery periods that involve pain from the trauma of surgery, inflammatory pain, neuropathic pain, and comorbid painful conditions. After a spinal fusion, patients are not able to use anti-inflammatory medications for at least 90 days after surgery due to the risks of slowed healing and non-union of the fusions. The current policy has been in place for many years, predating the current panel of surgeons and physician assistants. It reportedly developed in response to hospital leadership pressure to achieve pain management-related metrics on patient satisfaction surveys that influence reimbursement. The history of pain management and policies influencing the evolution of the current departmental policy parallel the high-profile opioid epidemic that has gained mass media and legislative attention recently. Out of concern for the undermanagement of pain, Dr. James Campbell introduced the notion of pain as a fifth vital sign in his 1996 presidential address to the American Pain Society with the intention of elevating pain assessment to the level of essential information to achieve more consistent evaluation and treatment. This caught on and was rapidly promoted nationally by the Veterans Health Administration and the Joint Commission. Metrics were added to measure from the patient's perspective how well their postoperative pain was managed while they were in the hospital. With an increased emphasis on pain assessment, patients began expecting there to be a treatment for their pain. Pharmaceutical companies seized the opportunity and started aggressively marketing opioid analgesics as the solution, grossly misbranding these medications as safe and inflating their efficacy. This strategy was successful in rapidly escalating the rates of prescribing of opioids. JACO introduced pain-related metrics to patient surveys in 1997 and started scoring them to influence reimbursement in 2001. The combination of the emphasis of the subjectivity of pain and the importance of alleviating it, coupled with the patient satisfaction influencing reimbursement, created momentum for the overprescribing of narcotics for pain management. In 2005, reports of prescription opioid-related deaths were first available, and by 2008, the rate of opioid-related deaths exceeded the combined total of deaths related to heroin and other street drugs. In response to the evolving epidemic, the federal government approved funding for research and sought collaboration of experts to advise policy changes and guidelines for rational prescribing and pain management. The recommendations that have emerged from this effort are evidence-based and require a comprehensive multidisciplinary approach to reverse the epidemic that has developed over the past couple of decades. Out of the legislative funding for research came the understanding of pain as a complex health issue that is influenced by comorbidities and requires management of biopsychosocial elements rather than the traditional biomedical approach. Utilizing risk stratification and a step treatment model of care, the Veterans Health Administration implemented and evaluated individualized, patient-centered, multidisciplinary, and multimodal pain care of veterans starting in 2009. The concentration of patients with complex pain and comorbidities is very high in the veteran population, which is more reflective of the neurosurgical patient population than the general population. Just as advancements in care of patients with amputations and PTSD have been made possible through the VA due to this type of disproportionate incidence of these conditions, their programs are bringing a better understanding of the complexities of pain care. The results of these program evaluations, though only rapid reviews have thus far been made available, provide some guidance on formative evaluation to develop evidence-based pain management programs. Washington State has led the national initiative to reverse the opioid epidemic since it was first recognized with the first report of prescription opioid-related deaths in 2005. In 2007, Washington State's Agency Medical Directors Group, or AMDG, developed the first guidelines that included a narcotic dose-based threshold for prescribing. With emerging evidence in 2010, the AMDG updated their guidelines, and Washington legislature repealed permissive prescribing rules and set new standards. The most recent update to the AMDG guidelines were published in 2015, and by January of 2019, Washington is due to implement prescribing rules that incorporate these guidelines with those of the CDC and the BRIE Collaborative published in 2016. The AMDG guidelines provide guidance for all phases of pain management, including acute, post-op pain, subacute pain, and chronic non-cancer pain. The other guidelines do not include postoperative pain or perioperative pain. Therefore, the AMDG is the most appropriate evidence-based prescribing guideline for the neurosurgical practice to align its policy with the proposed changes. Gap analysis of the current neurosurgical prescribing practices and the current prescribing guidelines could more accurately be described as a chasm analysis. The remarkable gap highlights how critically changes are needed. According to the Washington State Department of Health, as reported by the Opioid Prescribing Task Force in September of 2017, the state's efforts have been successful in achieving a 44% sustained decline in unintentional prescription opioid deaths. This sustained decline in unintentional prescription opioid deaths correlates precisely with a decrease in the rate of opioid prescribing. Unfortunately, this trend does not reflect the prescribing rates in the large, rural, geographically isolated counties that make up the neurosurgical practices patient population. In fact, the rate of opioid prescribing has remained constant over the past decade, well above the state and national rates, which is consistent with the neurosurgical unit's prescribing practices remaining unchanged. Revealed in the documents attached to this slide, including the organizational SWOT and financial SWOT analyses and a policy brief, the outlined pain management policy is not only ineffective, but it generates a significant source of waste to the department as well as to the organization. Despite the persistent problems encountered daily, initial inquiries about possibly changing practices were met with resistance and doubt regarding the surgeon's willingness to change the policy. These inquiries predated the courses that led to this proposal. With building external pressures to change practices and the addition of a physician assistant experienced in pain management, as well as some notable incidents of patients selling narcotics and even causing intentional injury and hardware failure to necessitate additional surgery to prolong access to the supply of narcotics, when I revisited this idea of my practicum project, I was met with overwhelming support by the physician assistants and my practice manager. As I explored the pulse of the core leadership on this issue for alignment of goals, I was further encouraged and invited to join additional system-wide efforts to lead the necessary changes for improving pain management across the organization. To review the attachments, click the image of the document from the slide view. A separate window will open in a PDF reader. The internal and external pressures to update the neurosurgical pain management policy are converging to create an unavoidable urgency to act on this issue. Already, patients are experiencing obstacles of dosing and quantity limits set by the state, by third-party payers, and even by retail pharmacies that delay or prevent patients from obtaining pain medication immediately after discharging from the hospital. The proposed changes will decrease some of these obstacles and delays by aligning ordered quantities with typical limits and allowing time to process necessary requests for authorization and overrides of limits. Cotter's 8-step change model was selected for the scoping system-wide changes to support the unit-based improvements and provide cohesion for continuity of practice. Cotter's model works well as the overarching change model for the scoping policy on pain management for the department that includes prescribing practices, transition from biomedical approach to a biopsychosocial approach, monitoring and accountability measures, screening and risk stratification processes, and for coordination and continuity of care. Each of these is a quality of improvement project, and the short-term wins of each implementation builds the comprehensive change that is the goal. Cotter's model works well with the teamwork and collaboration of the embedded transformational leadership within the department and the organizational cultures. The first step, a sense of urgency, was created with discussion of this issue with the practice manager, providers, organizational leadership, our Best Practices Council, interdisciplinary colleagues, Patient and Caregiver Experience Council, and the Patient Experience Improvement Steering Committee. Building a coalition and forming a strategic plan and initiatives involved engaging the department manager and the department providers and the practice manager in updating the departmental pain management policy and efforts to eliminate waste and decrease liability exposure, as well as to improve care. The coalition broadened with engagement of the RM Best Practices, where members will work on action plan for continuity of care, communication and dissemination of resources, and update policies regarding pain management at a quarterly best practices work session in September. Patient and Caregiver Experience Council set improvement of pain communication and experience as the priority issue and formed the Pain Experience Improvement Steering Committee to organize a task force to recommend an action plan that is system-wide. Enlistment of a volunteer army involved the PAs volunteering to collaborate on the departmental policy change. A steering committee met to consider who to include in the task force on the pain experience project. And RM Best Practices decided to have inpatient and outpatient department collaboration on the work session. Barriers that were considered for removing in order to enable action included the pilot program for the electronic narcotics prescribing approval in our department. That is set for the end of this year, but we need some further clarification on that. The Chief Nursing Officer authorized the funding of the Best Practices event to increase participation, and the limitation of provider availability to be present for task force sessions was recognized by the steering committee, and consideration of support staff being liaisons at the meeting to communicate next steps and questions and feedback to move efforts forward. Current low census due to the departmental crisis that we're involved in provides an opportunity of time to invest in this time-intensive change. Cotter's 6th step is to generate short-term wins. I've chosen the PDSA change model for this because it is appropriate for developing new process to accommodate quick action for progressive modifications as the changes are implemented. Each of the items listed in the previous slide that were individual quality improvement projects would be appropriate for a separate PDSA cycle that are in concurrent progress. The organization and department routinely utilize the PDSA model for quality improvement projects, so this is a model with which the team is familiar. With short-term wins and continuous improvement facilitated by the PDSA model, the quality improvement acceleration would be sustained and disseminated for institutionalization of the changes, which are Cotter's model's steps 7 and 8. In Given's 2010 Strategic Initiatives case study for hospital and healthcare, 4 driving questions for success in leading strategic initiatives were presented to increase the ability to build alignment and commitment for strategic initiatives. I chose these driving questions for my change proposal because the goal of this proposal is to strategically align the pain management policy with the current evidence-based guidelines. As a part of the planning phase of the PDSA model, we answer these driving questions. Why are we doing this and why now? Is the first of these questions. The current policy's only strength is that it is what our providers and patients are used to, and continuing with the status quo during the current state of crisis in our department is very tempting. However, the pressures to change are overwhelming and making the current practice too labor-intensive, wasteful, and riddled with complications to sustain. The weaknesses of the current policy and practices are much more compelling for immediate change. The current policy needs to be aligned with evidence-based guidelines, healthcare policy agenda, and the transformation of pain management and pain initiatives of the healthcare organization for continuity of care. Next, we ask, who needs to be involved? Who are the stakeholders? Development of the new policy requires engagement of the primary stakeholders, including the prescribing providers, the practice manager, the clinic's nursing staff, and inpatient pharmacists. For feedback, perspective, evaluation, and improvement of the proposed new policy, involvement of the patients, core leaders of the organization and other departments, and members of the Patient and Caregiver Experience Council and the RN Best Practices Council may be helpful to achieve and align efforts with the organization. Also a part of planning is choosing the leadership style for this project. Due to the urgency of action on this issue, utilizing pace-setting leadership within the embedded transformational leadership culture may achieve an acceleration of the action plan and implementation of changes. A dramatic shift from the cultural expectation of transformational leadership may be interpreted as a threat to the provider's autonomy and increased resistance to change if the changes proposed are received as imposed or as questioning the integrity of the provider's practices. Pace-setting leadership is described as effective when stakeholders are self-motivated and highly skilled, and when urgent action is needed and results are critical. Reinforcing necessary changes as consistent with the department's reputation for setting the standard of care excellence for the organization may help to generate momentum to accelerate transformative policy changes. The third driving question of our plan is, what exactly are we going to do? The first row of action items in this slide include some of the work that I've done so far. Next will be to seek the perspective of stakeholders to refine the recommendations into an action plan or draft of the policy to trial. Once the necessary resources are in place, we will set a date for which to implement the trial. Ongoing evaluation of new practices will be by scheduled meetings with the providers and other stakeholders weekly for 4 weeks and monthly for 3 months. By 16 weeks, with the kinks worked out, the refined policy will be formalized and disseminated to the core leadership for adapting and/or adopting in other departments. The policy will need to be updated annually, and that will require starting at square one, so to speak, with a review of the evidence-based guidelines, legislative changes, and identifying opportunities to improve the policy further. The neurosurgery practice's new pain management policy needs to consider the state and federal goals, actions, and priorities that comprise the responses to the opioid crisis. The Washington State Opioid Response Plan is shown here. Neurosurgery's place in this plan is primarily to work on goal number 1, to prevent opioid misuse and abuse by improving prescribing practices. The 2017 Washington State Patrol Opioid Summit Report details 7 goals and recommendations for action to meet these goals. Goal number 1 is addressing gaps in public awareness of the risks of opioids and the less risky alternatives that are available. The neurosurgery practice's responsibility in this is to patient education on the risks versus benefits of the medications, and transition to a more comprehensive pain care model that considers the biopsychosocial elements and comorbidities, emphasizing a multimodal treatment plan to minimize dependence on narcotic medications. Goal number 2 is prevent addiction by curtailing overprescribing. Overhauling the prescribing practices to limit quantities dispensed and implementing a structured tapering of medications that is facilitated through weekly prescriptions rather than dispensing arbitrary large quantities upon request will help with this goal. Adding pain management agreements that acknowledge patient education related to medications, risks, alternatives, and plan to taper use after surgery is another way to establish expectations prior to surgery for patients to need less medication as they heal. Goal number 3 is to reduce illicit use of prescription opioids. Providers should consult the prescription monitoring program prior to prescribing and utilize office visits, pill counts, and urine drug screens if patients are not adhering to the tapering schedule. Implementing the electronic narcotic prescribing is necessary to make sure that prescriptions are secure, and we can manage things more closely if we're able to order the prescriptions electronically. Once this is implemented, we can eliminate the paper prescriptions, which is one of the goals identified by the Washington State Patrol Summit Report. Goal number 4 is disrupt and dismantle trafficking of narcotics. Some of the ways we can help with this is requiring police reports for any reported lost or stolen prescriptions, working closely with case managers and coordinated care for monitoring and accountability of patients with complex case histories involving substance abuse, addiction, and criminal behaviors and convictions. Goal number 5 is prevent further increases in overdose deaths. Primarily, this is addressed in the actions related to goal number 2 to prevent overprescribing as it relates to neurosurgery. But we can also order naloxone and educate patients and family members on its use as a part of the discharge patient teaching. Goal number 6 is improve overdose reporting and information sharing. With this, we can work with the healthcare organization to add the specialty providers, such as neurosurgery, to the notifications when patients are seen in the emergency department. The primary care providers are notified of this, but not the surgeons. And they should also be advised if there's any incidents of overdose while they're under the surgeon's care for pain management. Copies of the signed pain management agreements to the primary care providers following the preoperative appointment to communicate the limits of the pain management by the specialty with the expectation of the primary care provider resuming management of the pain medications at the end of that specified period would also help with that. Goal number 7 is to expand access to addiction treatment. So with this, the implementation of risk stratification and referrals to pain specialists and other resources for therapies and alternative treatments can help patients achieve better pain management and appropriate referrals to specialists when they're not responsive to the efforts to taper the use of the medications as planned. The other picture in this slide is the 2017 CDC poster that identifies specific actions for identification of prescribing practices that contribute to the opioid epidemic and actions that are part of the solution. For the first problem, too many prescriptions, the solution might be to use the biopsychosocial approach to provide multidisciplinary, multimodal pain care that minimizes the need for narcotics. The next problem identified is too many days, and it specifies that 3 months increases the risk of addiction by 15 times. Limiting prescriptions to a maximum of 7-day supply with a structured taper to at or below the preoperative use by 6 weeks would address this problem. The next problem is doses too high. The usual prescription for discharging patients and for the 90 days of the post-op pain management period is 120 to 180 milligram morphine milligram equivalents. The slide shows that, or the poster shows that 50 morphine milligram equivalents daily doubles the risk of overdose versus a 20 milligram morphine milligram equivalent. 90 milligram morphine equivalent or more increases the risk of overdose by 10 times. Using the lowest effective dose and tapering intentionally would help to address this problem. Patients requiring more than 120 milligrams morphine milligram equivalent immediately post-op should be referred to a specialist. And if at 4 weeks the patients are using more than 90 milligram morphine equivalents, they would also need to be referred to a specialist. And then if they're not at or below the pre-op use by 6 weeks post-op, that would be another indication to refer to a specialist to identify this or to address this problem with a solution. The 2015 Agency Medical Directors Guideline provides evidence-based recommendations for management of all phases of pain. The complexity of developing a pain management policy for the neurosurgery practice first needs to consider that the plan needs to be patient-centered, individualized, and procedure-specific. These variables make updating the policy very challenging. For opiate-naive patients, few they may be, the plan is relatively simple progression that may not need to advance past the acute phase. Most may be able to discontinue use of narcotics by 4 weeks post-op or even a few days after surgery. For less invasive procedures, patients may not need narcotics and they should not be ordered unless they are needed. Upon review of inpatient progress notes, there are patients that refuse narcotics in the hospital and they are still provided a paper prescription for 120 tablets of a narcotic and 90 tablets of a muscle relaxant. The presence of chronic pain and comorbid painful chronic conditions is more commonly the case with neurosurgery patients. By the time someone is approved to undergo a spinal surgery, they have typically taken narcotics for years, if not decades. Starting with chronic phase with opioid tolerances and dependencies already a reality complicates post-op pain management incredibly. Long-term use of narcotics causes changes that oversensitize receptors and open channels for increased neurotransmission of painful stimuli, thus escalating the perception of pain intensity. For those with neuropathic pain, the long-term use of narcotics may worsen nerve dysfunction, making outcomes less optimal and recovery more miserable. For these patients, the first 6 weeks after surgery usually require increased dosing of narcotics than their usual regimen. Tapering to at or below the pre-op use by 6 weeks post-op is a reasonable goal for patients that do not have comorbid inflammatory pain conditions such as gout, osteoarthritis, rheumatoid arthritis, etc. However, for 90 days post-op, patients that have fusions are advised not to take NSAIDs or other anti-inflammatory medications that may slow healing or cause non-union of a spinal fusion. For patients with these conditions, tapering to pre-op use may only be achieved when they are able to resume anti-inflammatory medications. Thorough analysis of the guidelines led to the following preliminary recommendations for the new pain management policy in neurosurgery. The organization has approved a pilot of electronic narcotics prescribing in neurosurgery by the end of 2018. However, we do not have a date for this to occur yet, and clarification on that point needs to be made a priority. Reinforcing the critical urgency of this resource may be necessary if administration does not have a clear commitment to making this happen. Limiting the supply upon discharge of medications that are dispensed improves patient safety, facilitates structured tapering of the medication, improves safety of the community, and decreases the risk of narcotics being used by anyone other than the intended patient. Providing the second prescription upon discharge would allow the patients that are not living in the area to have enough medication available to allow time for requesting refill adjustments, processing any necessary prior authorizations or overrides of limits by third-party payers. The separate prescription also increases the likelihood that patients will adhere to the plan to taper the use of the medications over providing an increased quantity on one prescription. For local patients, the prescription may be picked up during clinic hours if or when it's needed rather than being provided upon discharge. Patients experiencing pain that is not managed to a tolerable level or that are unable or unwilling to taper the use as planned need to be evaluated by the providers in the clinic. Development of a procedure-specific guideline for pain management will help to individualize plans of care to include what activities, therapies, non-pharm treatments may be encouraged, what medications and dosing are expected, and for how long, and any other specific precautions or recommendations to support recovery that is different depending on the procedure and the patient. The veteran patient population and neurosurgery share the commonality of a high concentration of complex pain and comorbid chronic conditions that influence pain management. Therefore, the program evaluation from the VHA should guide neurosurgery in utilizing an already validated screening tool, risk stratification, step care model, and biopsychosocial approaches for implementing evidence-based pain management without recreating the wheel. Many neurosurgery patients would benefit from health optimization prior to surgery for best recoveries. Prehabilitation is a novel concept that is being piloted in the organization's oncology department. They've achieved some great success with this pilot project, and expansion of this concept to neurosurgery patients has a fantastic potential to motivate patients to work on multimodal approaches that may help manage symptoms pre and post-op, increase strength, nutritional status, and coping mechanisms preoperatively. If this were a part of the policy for patients with moderate to high risk stratifications that were identified in the screening, patient compliance with these recommendations would likely increase because it was ordered as a prelude to their long-anticipated surgeries. So many patients have so little hope left when they reach neurosurgery that they're just waiting for surgery, during which time they become weaker, unhealthy, malnourished, and in a state that will impair their ability to recover from surgery. Providers are concerned that they will not have time to calculate the tapered use of medications in such an individualized manner. By collaborating with pharmacists to develop the structured schedules, they will be aware of this effort and supportive of consults prior to the discharge of patients with recommendations noted in their progress notes. Based on the pharmacist's recommendations, the tapering schedule may also be noted as a recommendation and copied into the discharge summary by the provider. This would also guide the case manager to obtain any necessary authorization or override on the prescriptions provided upon discharge. With the notes clearly indicated, the plan will be added to the after-visit summary for the patient's reference. Inpatient nurses would then reinforce this plan with the patient discharge education. The EPIC team could help us develop smart phrases and process optimization to increase efficiency for the providers to minimize the time burden of this new process. Continuing with our preliminary recommendations, a formal pain management agreement facilitates consistently providing patient education on risks and benefits of medications and alternatives recommended for management of pain. It also makes clear the patient and provider responsibilities and expectations for medication management, refills, securing medications and prescriptions from loss, diversion, or theft, properly disposing of unused medications, duration of pain management, and a plan to transfer care at the specified end date. This agreement will set the patient's expectations for tapering the use of the medications. This agreement will also serve to facilitate coordination of care between neurosurgery providers and the primary care providers or pain specialists. Limiting the management of pain medications by neurosurgery providers to 42 days is consistent with the guidelines for when patients should be at or below preoperative use of medications and when many third-party payers and Medicaid plans are requiring attestations related to transitioning to chronic pain management. The only patients at this duration that this may not work with are those that suffer from inflammatory chronic pain conditions. These patients may not realistically achieve adequate pain management until at least 90 days post-op when they are able to resume the use of their anti-inflammatory medications. This should be discussed with patients and specified in the preoperative pain management agreement. If primary care providers or pain specialists are willing to resume management of medications sooner, the neurosurgery providers are always willing to defer this to them. This is often a better arrangement, especially if the patient is not a local resident and if they have an established pain management provider with whom they work well, and whether or not that's the primary care provider or a specialist. With the legislative movement toward increased access to medically assisted treatment of opioid addiction, more patients are presenting for necessary surgeries that are currently on medications that necessitate management by a specialist, such as Suboxone, buprenorphine, and methadone. We have recently had a couple of these patients, and despite pharmacy consultations and utilization of every option known to the providers, adequate pain management was never achieved for these patients during the 90-day post-op period. These patients and patients on high doses of narcotics prior to surgery may need specialist-led pain management immediately after surgery. For patients that are not able or willing to taper as expected would also benefit from earlier referral to a specialist to avoid increasing the risks of addiction and/or overdoses. These are considerations to support establishing clear criteria for if and when to refer patients to specialists and when specialist management of pain needs to be the original plan for immediate post-op. I offer a preliminary recommendation of thresholds as follows. Anyone with history of addiction, abuse, aberrant behavior, or currently on medically assisted treatments should require a pain specialist to manage their pain medications, and no prescriptions should be ordered by the neurosurgery providers. Referral to a pain specialist to manage a next fill after surgery, after discharge, would be necessary if the morphine daily equivalent at discharge was more than 120 milligrams. If at 4 weeks post-op, the patient is at 90 milligram morphine equivalent daily or greater, patients would also be referred to a pain specialist. And referral would take place at 6 weeks if they had not managed to taper to at or below the pre-op levels. So the fourth driving question of our plan is, when are we going to do this? And the answer to that is now. There's great momentum for this change and great support by the stakeholders. Planning is well in progress, and the challenge will be to get the providers together to review the recommendations and get their commitments to action. I anticipate with the current turmoil in the department, even though the providers are in support of this change, getting them to the implementation phase may be a challenge due to all of the uncertainty and instability affecting the practice. On the other hand, they will not be able to delay action very long. If they do, the changes will be imposed rather than chosen. Always more difficult, but that might be necessary. Either way, the review of the evidence-based guidelines and recommendations that have come from this effort will be helpful for whatever next steps are possible and palatable. Moving on to do of the PDSA model. What do we need to do next? I will be meeting with the department's physician assistants to get their feedback on this proposal and to provide their perspective on the feasibility of the recommendations. With this feedback, we will refine the proposal to present at the next provider meeting, which we hope will be in September, if not sooner. The timing will depend on how things play out in the next couple of weeks. Once we get the go-ahead to implement a trial of the proposed changes, we will need to develop the structure of this plan by working with pharmacy to develop prescribing and tapering schedules that are procedure specific. I will adapt or create a pain management agreement and submit it for review by the practice manager, the director, and by legal. The RM best practice team will be working on evidence-based measures for non-pharm complementary measures for management of pain and preparation of a proposal to expand the prehabilitation program that is being piloted in oncology. Neurosurgery adaptations to this program will incorporate the biopsychosocial approaches that have been effective for the VHA programs. We will need to set a date to start implementing the changes for the trial of the new policy with communication and education to all affected providers and caregivers to facilitate continuity of care and utilization. Moving on to the study phase, once the changes are implemented, we will schedule meetings with the providers weekly for 4 weeks, monthly for 3 months to evaluate the changes and make necessary modifications. In our ACT phase of the PDSA model, after 16 weeks of the trial, it will be time to formalize the approval of the new policy so it may be institutionalized and disseminated across the system. The practice manager will report to the director, and I will report to the RN Best Practice Council and Patient and Caregiver Experience Council and the Pain Experience Task Force. Core leadership from other practices will be briefed on the changes as well and welcome to adapt the new policy for updating their policies. So the impact to the organization and the department, the burden of the proposed changes, this is a huge change. This is a much more complex than simply prescribing less pills. And in the current state of grief, crisis, and recovery in our department, the situation has left our entire team depleted. So taking on something this big might be too much at this time, until we have some answers on the direction of the current situation, which we expect hopefully in the next week or so. The potential for this necessary change is to provide a purpose to help the team cope with the situation in working towards an achievable goal. Another burden to the system is the cost of the DEA system for narcotics prescribing, but this was already approved, but it's still a cost to recognize. The additional use of pharmacists, inpatient pharmacists for consultations and recommended tapering schedules prior to discharge may be an influence, but they're already on staff, so this may not be significant. There's a likely increase in the time necessary for discharging patients initially by the providers until they get more familiar with the new process. Once they get familiar with that process, this time burden should be minimal. But now is a good time to try it out because with our low census, we have less patients that are having surgery and less patients that need to be discharged. Time and effort to review tools and options for psychosocial pain care, creating the pain management agreement, updating the patient education materials and spine class materials and video is quite an investment in time, but with the low census and less patients, this is a great time to do this time-intensive task. After the policy is implemented and the kinks are all worked out, so it's achieving the goals, the cost of labor and time spent on the pain management should decrease and patient care satisfaction should increase, and providers will be compliant with prescribing guidelines in advance of the new prescribing rules, hopefully. The expected outcomes for patients include better pain management, improved recovery from surgery, smoother transitions for discontinuing the use of medications or to transition to chronic pain management by their primary care or pain specialists. They should also have a clear understanding of the benefits versus the risks of their medications and alternative options for pain care. And they will be receiving evidence-based quality care for best outcomes, which should improve their patient experience and satisfaction. The expected outcomes for the neurosurgery providers include facilitation of rational evidence-based prescribing, alignment of practices with rules that are due to be imposed in January, less ambiguity for management of complex pain issues and more consistency in the care of the patients. This policy should also improve relations and coordination of care with primary care and pain management specialists, and decrease personal and professional liability, and improve team and patient satisfaction. The expected outcomes for the neurosurgery department and healthcare organization include achieving lean goals of replacing wasteful and ineffective practices with comprehensive evidence-based practices, decreasing liability exposure, possible expansion of revenue sources with the prehabilitation and pain management program, improved provider, team, and patient satisfaction, optimization of reimbursement potential related to satisfaction scores, which should translate to inpatient experience scores as well as the outpatient scores, and maintaining the high standard of care excellence that may be used as a model for other practices. In conclusion, the proposed policy change is timely, evidence-based, and critical to the sustainability of the practice. Despite the current turmoil, there is no better time to update this policy and bring practices up to evidence-based standards of care excellence. Alignment of the department policy and prescribing practices with current pain management guidelines is our duty to the community and our patients to do our part to reverse the opioid epidemic. And whether we choose to update this policy or not, by January 2019, legislatively imposed rules for rational prescribing are expected to obligate the recommendations of this proposal. You may access my reference list by clicking on the document in the middle of this slide from the slide view. By clicking on this, it will open a PDF reader in a separate window for you to view the document. Thank you for viewing my presentation, and I welcome any feedback or questions.